question here, the client with obesity diagnosed with the pulmonary embolism. Which assessment data should the nurse expect to find? Select all type. So here it's mentioning some sign and symptom of pulmonary embolism. Which one is appropriate for pulmonary embolism? We know that pulmonary embolism is a life-threatening blockage in pulmonary vasculature, most common cause by the deep vein thrombosis. Bradycardia, it is not a sign because patient develop trachycardia or trachypnea. Trachycardia is there. Increase the heart rate or also increase the respiratory rate, both. Chest pain. Usually patient complain the pain on inspiration. This is the choice. Patient do not have any chill or fever. It is not an infection. Pulmonary embolism, we said the blocking of the circulation, definitely oxygen supply will be reduced. It's called hypoxemia. So blood supply will be reduced in the blood. Tachycardia and tracheal deviation. Tracheal deviation is the common sign in pneumothorax, because in pneumothorax, lung collapse due to the air in the pleural space. The key symptom is hyperresonance. And in tension pneumothorax, basically trachea is deviated. It is not the sign of pulmonary embolism. So other sign of pulmonary embolism, patient have a hypotension, diaphoresis, petechia, and anxiety. Let me read it first. This is the showing pulmonary embolism here. And here you see deep vein thrombosis or DVT. Deep vein thrombosis started from the leg, then they travel through the vena cava, enter to the lungs, and causes the bifurcation and occlusion and develop the pulmonary embolism. So usually the blood clot formation in thrombosis, they are fixed, not travel to the body. But emboli, when broke down and travel to the body, patient has a complication start. And emboli, this is the left pulmonary artery occlude by emboli. So this is the emboli because of thrombophlebitis or DVT. So let me read it. The pulmonary emboli is a blood clot that usually originate from deep vein of leg, travel to the pulmonary circulation and obstruct the pulmonary artery or one of its branches. Because inside the lungs, inside the brain, the microcirculation is there. So result in the decrease the perfusion in relation to the ventilation and impaired gas exchange develop the hypoxemia, right? So decrease the perfusion and impaired gas exchange, so lead to the hypoxemia. So when we go check the arterial blood gas analysis, we can find the imbalance. Also, client at the risk for formation the venous thrombosis when the condition delayed details with varicose. So there are three signs together we call varicose. The client at the risks for pulmonary embolism include those with prolonged immobilization, like during hospitalized, obesity, surgical operation, varicose vein, smoking, heart failure, advanced age, and history of deep vein thrombosis or thromboembolism. So what are the risk factors? Prolonged bed rest, any major surgery, long plane traveling, pregnancy, obesity, congestive heart failure, long bone fracture, smoking, and oral contraceptive. And in this note, explain again what are the data, sign and symptom of pulmonary embolism. 85% patient have shortness of breath, we call dyspnea. 60% patient has a chest pain, more accurate, pleurotic chest pain or pleural friction rub. Patient has a tachycardia, tachypnea, but hypotension. Heart rate increase, respiratory rate increase, but blood pressure go down. Patient develop hypoxemia, impaired gas exchange, decreased perfusion, right? And also patient develop anxiety or restlessness and cough. So also here talking about atypical presentation, less important, but I want to read it with you. So atypical presentation can be associated with a large size emboli, may include cardiopulmonary compromise or hemodynamic instability like right ventricle dysfunction, pulmonary hypertension, systemic hypotension, syncope or syncope, loss of consciousness, also distended neck pain. What are the education objectives? The classic clinical presentation of pulmonary embolism include dyspnea, pleurotic chest pain, tachycardia, tachypnea, hypoxemia, and feeling of apprehension and anxiety. Super important for NCLEX board. Risk factor related to the varicose. What is varicose? When a patient have all of these three signs together, like hypercoagulability, venous stasis, like thrombophlebitis or deep vein thrombosis or pulmonary embolism, also endothelial damage. These three together we call varicose. Massive pulmonary embolism can cause syncope and hemodynamic instability. It is the life-threatening medical emergencies. We need immediate care. The question: A nursing diagnosis of ineffective airway cleaning related to the pain is identified for a client who had open abdominal surgery 2 days ago. Which intervention should the nurse implement first? So in this question, examiner make it easy for us, mentioning ineffective airway cleaning because of pain, right? And patient has a history of abdominal surgery 2 days ago. Which intervention should the nurse implement first? Number one, administer prescribed analgesic medication for incisional pain. Second, encouraging use of incentive spirometer every 2 hours. Offer an abdominal pillow to splint the incision with coughing, and promote increased oral fluid intake. So, encouraging fluid intake, tell them to use spirometer or breathing technique. All is important, but the pain management is a priority. You know, the pain is a vital sign, and also pain management, also the rule of Maslow's law. What are the first demand? We have to fill it up. So patient has an ineffective airway clearing because of pain. So underlying cause, if you remove, everything will be okay. So also this is the make easy because admin prescribed, this say, as a RN, which is our role, accountabilities, responsibilities, we give them medication as prescribed. So give them pain medication, analgesic medication for incisional pain. This is the first priority. Then you can make sure your patient take enough fluid or using the spirometer. But after all this, let me explain and read it and get more information gather. Post-operative clients are at the risk to develop atelectasis and possible for pneumonia. So atelectasis means the partial or complete collapse of the lung, and pneumonia means the inflammation or infection in the lungs. Both can possible after the surgery. So we have to take care of them. So always we have to check the upper respiratory tract. Is it clear or not clear? And infection develop because of retained secretion. Effective coughing is essential to prevent those complications. The nurses can promote many client action that will facilitate effective coughing, and this include the splinting the incision while coughing, changing the position every 1 to 2 hours, also movement the patient or ambulating the client, using an spirometer or hydration adequately to the patient, also important. However, all of these interventions are less effective if the client is in pain. The healthcare provider should instruct the client to require plain medication before pain becomes intense. Pain relief should be addressed prior to implementing the coughing, right, and also ambulation. What are the education objectives? The nurse should ensure that the postoperative client has effective pain relief before performing the coughing exercise. Clinical question here. The nurse is promoting care for a client with a cancer in the left lung who is undergo the video assisted thoracic surgery in the morning. Will, right? A patient diagnosed by lung cancer and patient is ready to go for thoracic surgery. The client is nervous, jumpy, shortness of breath. Pulse is high, 120 per minute. Respiration are high, 30 per minute, but shallow. Expiratory wheezing. So when you check the lungs, we get wheezing, means bronchoconstriction, right? Which of the following is the priority of nursing action? Read the question very carefully. There are 4 options, but which one you do the first? A patient diagnosed the lung cancer will go for the surgical operation. Before surgical operation, they are nervous, shortness of breath, nothing abnormal. They will be nervous, right? On examination, we get the tachycardia, tachypnea, and also shallow respiration. Wheezing is there, means bronchoconstriction. So what are the priorities? Admin intravenous morphine. Morphine is good medication for pain, can reduce the anxiety, but my patient has a shallow respiration, is not a good decision to give them morphine. Respiratory therapist admin inhale bronchodilator. Patient has a wheezing, it indicates they have a bronchoconstriction. You give them salbutamol as a bronchodilator. Oxygen, it is a good choice. But what next? Place the head of the bed in a Fowler posture or high Fowler. So when a respiratory problem patient, position is most important. When you keep the patient in the good position like Fowler or high Fowler, their chest will be expand maximum, or orthostatic posture, tripod posture, all is important for the patient. The examiner asking which is the most important priority. What you do first, it will not take time. Tell your patient or keep your patient or head of the bed of the end, keep upright, Fowler or high Fowler or orthopenic position. It can facilitate the patient for respiration. Then you give them bronchodilator or other intervention. Stay with the client, encouraging the client. Yes, I will be there. I will explain everything. Then patient will feel good, get confident, reduce the anxiety. But not first priority. Positioning is the first important here. Let me read the explanation. It can help you for better understanding. So uh, elevating the head of the bed to the polar or high polar position is the priority of nursing action to help relieve the shortness of breath, increase the oxygen supply, and also promote lung expansion, right? So reduce shortness of breath, increase oxygen supply, and promote lung expansion. Just simply good positioning of the patient, and it is high polar posture or orthopenic posture or tripod posture, anyone. So orthopenic means sitting in a chair on the side or on bed, leaning over the bedside table. Tripod means sitting in a chair, leaning forward with the hands or elbow resting on the knee. Both can help more oxygen, promote lung expansion, and reduce the shortness of breath. Right? So elevating the head and chest in high polar positioning, orthopenic or tripod, allowing the maximum lung expansion and promote oxygen, especially in the client with dyspnea, COPD, bronchial asthma, or lung cancer, or pneumonia. Question here, the nurse perform admission history for a 70-year-old client with newly diagnosed chronic obstructive pulmonary disease, shortly called COPD. Which statement made by the client does the nurse recognize as a more significant contributing factor to develop COPD? What are the significant factor, or what are the sign, symptom, or risk factor including or favor to diagnose COPD? Select all. Number one, I have been drinking alcohol almost daily. So alcohol does not have any relationship with COPD. If patient give the history of smoking, smoking is related with COPD. So increase the incidence in cigarette smoking, right? Not alcohol. I have been overweight for as long as I remember. So overweighting or obesity is not related with COPD. I have smoked about a pack of cigarette a day since I was 16 years old, but now I stopped it. But I said the COPD is related to the in cigarette smoking, active or passive, any. I know I ate too much fast food. It is not related to the COPD. I was a car mechanic for 40 years and had my own garage. So occupation history is important. Okay, occupational. So now I said COPD, out of the 5, COPD related to smoking and occupation. Basically, COPD, we called 2 symptoms. One is emphysema, other is a chronic bronchitis. And most underlying risk factor is smoking. Most important, I said. Now here showing a table where the etiology associated with COPD, like tobacco smoke, active or passive, is it the important factor and irreversible? Occupational exposure to chemicals or dust, like carbon monoxide or fuel. So prolonged exposure can cause inflammation of the lungs and causes the pulmonary disease. So chronic obstructive pulmonary disease, chronic airway limitation or limited airflow in and out in the lungs. Air pollution, they also causes inflammation of the airway, or some genetic factor we called alpha 1 antitrypsin deficiency also can cause the COPD. Here's some note about the COPD. Let me read it. So chronic obstructive pulmonary disease generally refer to two conditions. One is emphysema. Emphysema means loss of lung elasticity and hyperinflation of lung tissue, and chronic bronchitis or bronchitis means inflammation of the lungs. It occurs most commonly in 70 decade of life. COPD is categorized by slowly progressive, persistent airflow obstruction that is closely associated with chronic airway inflammation, right? The risk factor is tobacco smoke, like cigarette, pipe, cigar. Although the client quit smoking or completely stop the suggestion the cigarette, this patient smoked a day for 53 years. The smoking is working as a car mechanics. We're talking about this patient in this scenario. 40 years as a major risk factor because prolonged exposure of carbon monoxide forms, so chronic irritation of the airway. Exposed to irritating chemicals, foams, vapor, smoking increase the risks to develop the COPD. So here, let me tell you, the COPD patient basically present with dyspnea upon exertion. If you check the lungs, we can get the wheezing or crackles. Patient usually barrel-shaped chest and use the accessory muscle for respiration, clubbing, hyperresonance, or decrease the saturation of oxygen level and also rapid shallow respiration. So before to go education objectives, I want to tell you what are the nursing care for COPD. When we deal with the patient with COPD, position of the patient in high Fowler, encouraging to cough, deep breathing, use of spirometer, encouraging proper nutrition, especially increase the calorie and protein, and educate patient about the breathing technique, maybe abdominal breathing or pursued lip breathing, right? A question usually NCLEX board asks, in case of COPD, what food we encouraging to eat them? High calorie, high protein, but low carbohydrate diet. Increase the respiratory, humidified air, and also suction is necessary. Definitely, we assessment the respiratory status of the patient, also encouraging pursued deep breathing exercise. Tell them completely stop the smoking, avoid exposure to the cold, give them influenza vaccine, pneumonia vaccine, right? It can prevent them for acute exacerbation. Okay. So usually when we give them medication, we give them bronchodilator, anti-inflammatory, or mucolytic agents. Now, educational objectives. Chronic airway inflammation is closely associated with development of COPD. Specific etiology factor, tobacco smoke, prolonged occupation exposure to chemicals or dust or air pollution, and genetic cause. It's called alpha-1 antitrypsin deficiency. That is more than enough COPD for NCLEX board exam.